Space is measured in time. And at the beginning of time, the universe had a pattern, rhythm. Within this universe, biological systems have evolved. They too have a rhythm and a beat. And a beating heart and breathing lungs have become the symbol of life itself. Down through the years, man has tried to devise methods to sustain the beating heart and breathing lungs. These have included beating the victim with sticks, warming the body with hot coals, blowing smoke into the body, and even inverting the person to drain the lungs. In more recent times, various manual techniques have been used for resuscitation. The Sylvester arm lift chest pressure method, the Howard squeeze the chest technique, Schaefer prone pressure, and Holger Nielsen arm lift back pressure. Now, cardiopulmonary resuscitation, or CPR, has been shown to be the most effective method for emergency artificial ventilation and artificial circulation. It has provided a prescription for life. In order to ensure effective performance of cardiopulmonary resuscitation, every medical, paramedical, and life-saving organization must provide a continuing program of training and practice in CPR. This requires educational materials, and resuscitation emergencies may result from either respiratory arrest or cardiac arrest. Respiratory arrest is absent or inadequate breathing. This may result from respiratory failure or airway obstruction. Cardiac arrest is a sudden, unexpected cessation of heartbeat. There are three basic types of cardiac arrest. These are cardiovascular collapse, or electromechanical dissociation, ventricular fibrillation, and cardiac standstill, or asystole. The normal heartbeat is rhythmic, synchronous, and forceful. It produces a peripheral pulse in the three types of cardiac arrest. In cardiovascular collapse or electromechanical dissociation, the heart is ineffective and there is no pulse, even though electrical conduction is present on the monitor. Ventricular fibrillation is an uncoordinated, ineffectual beating of the individual muscle fibers. There is no pulse or blood pressure. In cardiac standstill, the heartbeat is absent. There is no pulse, no blood pressure, and no blood flow. All three types of cardiac arrest can be recognized by checking for three buttons. For loss of consciousness by shaking the person. Check for absent breathing by looking at the chest and listening and feeling for air exchange at the mouth and nose. And check for absent pulse by feeling for the carotid artery at the side of the neck. When respiratory arrest or cardiac arrest is recognized, resuscitation must be started immediately. Cardiopulmonary resuscitation, also known as CPR, has two major components. These are basic life support and advanced life support, both of which will be presented in this film. The A, B, C steps of basic life support are: A, open the airway; B, restore breathing; and C, restore circulation. In an emergency, after determining unconsciousness, the first consideration is A, open the airway. X-ray illustrate an airway blocked by the tongue and an open airway. An unconscious patient, the lower jaw drops back and the tongue blocks the pharynx. Lifting back and tilting the head back draws the lower jaw and tongue forward and opens the airway. This can be demonstrated on a cadaver dissection on which important structures have been colored to aid in recognition. The simplest way to correct obstruction of the pharynx by the tongue is to tilt the head backward into maximum extension. The addition of chin lift may assist in further opening of the airway. If these steps do not open the airway, place your fingers behind the angles of the jaw and thrust the jaw, opening the airway. Look, listen, and feel for spontaneous breathing. If breathing is absent, begin D, breathing for the patient. To perform mouth-to-mouth ventilation, tilt the head back, seal the nose, open your mouth, make a tight seal around the patient, and blow in until you feel the lungs expand and see the chest rise. Remove your mouth to allow exhalation. Repeat every 5 seconds. Mouth-to-nose ventilation is an alternate method. Keep the head tilted back, seal the mouth with your cheek or finger, and inflate the lungs through the nose. Watch the chest fall during exhalation. It may be necessary to open the mouth for exhalation. Mouth-to-nose may be useful where there are injuries to the mouth, absent dentures, or a muscular spasm. In a resuscitation emergency, check for unconsciousness. Tilt the head and look, listen for breathing. If breathing is absent, initial ventilation of the lungs should be 4 quick breaths without allowing time for full lung deflation. This assures effective expansion of the lungs. If breathing does not start, check the carotid pulse. Place your fingers on the Adam's apple and slide them into the groove at the side of the windpipe. Practice feeling the carotid pulse on another trainee. If the pulse is absent, immediately begin external cardiac compression. This provides artificial circulation. Proper hand placement for external cardiac compression is approximately 1.5 inches from the xiphoid, or tip of the sternum. To locate this, place 2 fingers on the xiphoid, place the heel of one hand next to them on the lower 1/2 of the sternum, and the other hand on top. Avoid pressure over the xiphoid since this can cause injuries to underlying structures. Note that only the heel of one hand compresses the sternum, and that the fingers do not touch the chest. Interlacing fingers may assist in keeping them off the chest. As shown on this sagittal section, external cardiac compression compresses the heart between the sternum and the spine and forces blood from the right ventricle to the lungs, from the left ventricle to all of the body. You have now seen how to perform the ABC steps of basic life support by mouth-to-mouth ventilation and external cardiac compression. A and B provide artificial ventilation for respiratory arrest. It must be combined with artificial circulation when cardiac arrest occurs. Artificial ventilation plus artificial circulation provides CPR. CPR is performed best by 2 rescuers, as demonstrated here on a person under general anesthesia. One rescuer compresses the chest at a rate of 60 per minute. The other one inflates the lungs by interposing breaths between each 5 compressions without any interruption in compressions. As shown on the tracings, blood pressure of 100 millimeters of mercury or more and 1/3 of the normal blood flow to the brain is provided by 1.5 to 2 inches of compression. Any external cardiac compression results in a precipitous drop in blood flow and blood pressure. This demonstration of 5-second pauses emphasizes the necessity for a continuous, uninterrupted rhythm. Check the pulse after the first minute of CPR and every few minutes thereafter. This will indicate the effectiveness of external cardiac compression or the return of a spontaneous heartbeat. Check the pupils periodically during CPR. When the eyelid is lifted, the normal constricts. Following cardiac arrest, the pupil dilates. Dilated and fixed pupil indicate serious brain damage is imminent. Remember, pupillary responses may be altered by some diseases and drugs. Optimum performance of CPR requires training and retraining on lifelike mannequins. 2 rescues CPR is demonstrated here. One rescuer compresses the chest at a rate of 60 per minute. The other rescuer interposes breaths between each 5 compressions without any pause in compressions. Ventilation is easier and more effective when the breaths are interposed between compressions. When there is only one rescuer, he must perform both artificial circulation and artificial ventilation. a ratio of 15 compressions to 2 ventilations is used. The compression rate is faster, 80 per minute, in order to achieve an actual compression rate of about 60 per minute because of the interruptions required for the 2 quick full ventilations. Repeat this 15 to 2 cycle until help arrives. Here is a summary of the recommended techniques for 2 rescuer and 1 rescuer CPR. When there are 2 rescuers, use a ratio of 5 compressions to 1 ventilation. Compressions are at a rate of 60 per minute, and ventilations are interposed without any pauses in compression. When there is only 1 rescuer, use a ratio of 15 compressions to 2 ventilations. Compressions are at a rate of 80 per minute, and each 2 ventilations should be given quickly. Whether there are 2 rescuers or 1 rescuer, remember the important rule. Never interrupt CPR for more than 5 seconds. A few exceptions are difficult endotracheal intubation or during the movement of a victim up or down stairs. When prolonged CPR is required, if there are 2 rescuers, they can change positions without interrupting compressions. This technique is shown here on a torso mannequin. This automated trainer tester has signal lights which indicate adequacy of ventilation, adequacy of compression, and mistakes in hand position. It all has to provide an exact score. The sequence of steps is demonstrated here on an automated mannequin with colored lights to indicate adequacy of compression, adequacy of ventilation, and mistakes in hand position. A strip chart recorder provides a permanent record with exact details of performance. The record shows the effectiveness of 4 quick breaths, correct 15 to 2 1 rescuer CPR, and 5 to 1 2 rescuer CPR. Mistakes in hand position are shown below. The technique is modified for infants and small children. Tilt the head back and cover both the mouth and nose with your mouth. Use small puffs of air to inflate the lungs about 20 times per minute. To check the pulse, place the fingertips gently over the heart in the area of the left nipple. If the pulse is absent, use 2 fingers to compress the mid-sternum. Support the back with the other hand. Compress the sternum 100 times per minute and interpose breaths between each 5 compressions. For small children, use the heel of only 1 hand to compress the chest. Basic life support involves both recognition of cardiac arrest and proper performance of the ABC steps. These can now be related to each other and summarized as follows. In resuscitation emergencies, the first consideration is to check for loss of consciousness. If unconscious, A, open the airway. Look, listen, and feel for breathing. If breathing is absent, begin B, breathing for the victim. If spontaneous breathing does not resume, check for the carotid pulse. If the pulse is absent, begin C, artificial circulation for the victim. The ABCs of basic life support should always be started immediately in a resuscitation emergency. Adjunctive equipment is not required, and there should not be any delay to seek such adjuncts. When approved devices become available, and if you are well trained in their use, they can be effective in assisting with the performance of the ABCs. Insertion of a simple oropharyngeal airway assists in keeping the air passage open in an unconscious person. A transparent mask with an inflated cuff provides one of the simplest and most effective adjuncts for artificial ventilation. Masks used for mouth-to-mask resuscitation should ideally have an inlet to provide enrichment with oxygen when this becomes available. When bag valve mask devices are used, they should provide a well-fitting mask, a non-rebreathing valve, and a self-inflating bag with an oxygen inlet at the back and a reservoir that assures delivery of high concentrations of oxygen every time the bag is squeezed. The use of bag valve devices should be limited to highly trained professional and rescue personnel. This is because of the difficulties in maintaining a tight mask seal and head tilt with only one hand while squeezing the bag with the other hand. Bag valve devices can be used effectively with an esophageal obturator airway or an endotracheal tube. Mechanical ventilators provide artificial ventilation with pure oxygen. Manually triggered devices such as this are effective for ventilation via a mask. They inflate the lungs each time the trigger is activated. A high oxygen flow rate and a high pressure setting compensate for mask leaks or partial airway obstruction. These manually triggered devices can also provide effective ventilation during CPR because the high flow rate allows breaths to be interposed between chest compressions. In summary, manually triggered devices are effective for both artificial ventilation alone and for artificial ventilation in conjunction with CPR. Conversely, resuscitators that are pressure cycled cycle automatically. They can be effective for ventilation when there is a leak-proof connection to an esophageal obturator airway or an endotracheal tube. However, they do not compensate for leaks which occur frequently when a mask is used. Furthermore, with pressure cycle devices, ventilation is not effective during CPR. These devices should never be used during CPR because each external cardiac compression cycles the device into exhalation and prevents inflation of the lungs. Therefore, artificial ventilation is totally inadequate. Intermittent positive pressure breathing units used in hospitals for IPPB therapy are also pressure cycled. They too are not effective during CPR. In summary, pressure cycle devices should never be used during CPR. Endotracheal intubation assures an open airway, prevents gastric distension, and prevents aspiration of gastric contents. It is considered advanced life support because it requires special training to intubate quickly and skillfully in a resuscitation emergency. Endotracheal intubation can be practiced on an infant intubation mannequin with exact details of the airway. An adult intubation mannequin can also be used for practice of this technique. However, mannequin practice alone does not constitute sufficient training. Do not interrupt CPR to perform endotracheal intubation unless you have had special training. Once the trachea has been successfully intubated, effective ventilation is assured. An alternative to endotracheal intubation is use of an esophageal obturator airway. This looks similar to a cuffed endotracheal tube, but it is mounted on a mask. Has multiple openings in the area of the pharynx, and the end is blocked by an obturator. Its advantage is that it can be passed blindly without the skill required to visualize the larynx during insertion. This diagram shows the tube in the esophagus with the balloon inflated and the mask seated on the face. Air blown into the tube escapes through the openings in the pharynx and passes down the trachea. The balloon in the esophagus prevents gastric distension and prevents regurgitation of stomach contents. The lungs can then be ventilated through the esophageal airway by mouth-to-tube resuscitation or with bag valve device or by a manually triggered mechanical ventilator. Various machines can provide artificial circulation. This manually operated unit makes it easier to compress the chest, but a second rescuer is required to provide ventilation. Oxygen-powered machines provide both artificial circulation and artificial ventilation. Manual external cardiac compression must always be started first, and the mechanical device applied only when it becomes available and only with brief interruptions in CPR. Oxygen-powered mechanical ventilator compressors are useful when prolonged CPR is required or when resuscitation must be continued during transportation. Their use is restricted to highly trained professional personnel. Open chest resuscitation is required in some cases. However, this is a special advanced life support measure. and its performance is restricted to doctors and to hospitals or life support units. It must be combined with effective artificial ventilation. It is indicated when external CPR is not effective in producing a palpable peripheral pulse. It is also indicated in crushing chest injuries, cardiac tamponade, tension pneumothorax which cannot be decompressed immediately with a needle, and when there are chest deformities or severe emphysema. In these conditions, it may be necessary to open the chest quickly in the left fourth intercostal space and squeeze the heart in one hand, between two hands, or between one hand and the sternum. We have now covered the ABCs of basic life support, both without and with adjunctive equipment. As soon as basic life support has been started, attention should be directed to advanced life support. This includes diagnosis, defibrillation, drugs, and disposition. The performance of these is limited to doctors or specially trained nurses and paramedical personnel acting under medical supervision. Diagnosis of the exact status of the heart is made as quickly as possible from oscilloscopic or electrocardiographic tracings. The normal heartbeat produces a rhythmic electrocardiogram. This is altered during the following lethal rhythms that indicate cardiac arrest. During cardiovascular collapse, even though the electrocardiogram has a rhythmic pattern, the pulse and blood pressure are imperceptible. This also occurs in electromechanical dissociation. Ventricular fibrillation is diagnosed by an uncoordinated electrocardiogram. This is associated with absent pulse and blood pressure. In cardiac standstill or asystole, there is no electrical activity, no pulse, no blood pressure, no blood flow. In addition to these lethal arrhythmias, advanced life support personnel must have specialized training in the recognition and treatment of various other arrhythmias. These include major arrhythmias such as sinus bradycardia, frequent PVCs, ventricular tachycardia, third-degree AV block, and others. These require immediate attention since they may progress into cardiac arrest. Some arrhythmias are less serious, but they too require prompt recognition and medical attention. They include premature atrial contractions, occasional premature ventricular contractions, second-degree AV block, and numerous others. When the heart is in ventricular fibrillation, it must be defibrillated. If an ECG or monitor is not available, immediate blind defibrillation may be life-saving. Defibrillation is performed with capacitor discharge units that can be charged up to 300 or 400 watt-seconds of delivered energy. A full 400 watt-second discharge is shown here on a defibrillator tester. Comparable defibrillators, which are portable and battery-operated, can be used where line current is not available. CPR must be continued while drugs are administered and preparations are made to defibrillate the heart. The electrodes are coated with conductive paste, or they are placed on saline pads to the right of the upper sternum, below the clavicle, and over the apex of the heart. Quickly apply the electrodes with 15 to 20 pounds pressure and deliver the shock. If a palpable pulse is not restored, resume CPR. Repeated shocks may sometimes be required.
In a resuscitation emergency, the sequence of steps depends on whether a patient is being monitored. In a monitored witnessed arrest, a precordial thump is used. It should be a single thump only, delivered within the first minute after the arrest, and the rescuer should defibrillate or start CPR immediately if the thump is not effective. The precordial thump is not recommended for use on children.
A precordial thump is demonstrated here in slow motion. Place your fist on the mid-sternum, raise it 8 to 12 inches, deliver a quick single blow.
When an arrest is monitored, check the monitor. Check for unconsciousness. If unconscious, feel the pulse. If the pulse is absent, give a single precordial thump. Feel the pulse again. If pulse is not restored, Start CPR or defibrillate if indicated.
The treatment of cardiac arrest usually requires the administration of drugs. The two most essential drugs for the CPR emergency are sodium bicarbonate and epinephrine. Following cardiac arrest, a severe metabolic acidosis develops even if continuous effective CPR is performed. This chart shows in blue the fall in pH which occurs when sodium bicarbonate is not administered during CPR. The red tracing shows that if sodium bicarbonate is given intravenously every 10 minutes, or as indicated by arterial blood gas and pH measurements, it is possible to maintain the pH at near normal levels. The recommended initial dose of sodium bicarbonate is 1 milliequivalent per kilogram. This dose should be repeated if an effective circulation is not restored after defibrillation. Thereafter, additional doses should be 1/2 of the initial dose every 10 minutes during the CPR emergency or as governed by arterial blood gas and pH measurements. Epinephrine increases myocardial contractility and elevates perfusion pressure. It also assists in restoring electrical activity in cardiac standstill and enhances defibrillation from ventricular fibrillation. The initial dose should be 5 milliliters of a 1 to 10,000 solution. This should be repeated every 5 minutes during a resuscitation emergency. In cases of cardiac standstill, the administration of repeated doses of epinephrine and sodium bicarbonate while continuing effective CPR may restore a cardiac beat or may convert the standstill into a ventricular fibrillation, which can then be defibrillated. Other drugs may be required after an effective circulation has been restored. Atropine sulfate may be used for treatment of marked sinus bradycardia, particularly when accompanied by premature ventricular contractions or hypotension. Lidocaine is useful to depress myocardial irritability and combat PVCs and ventricular tachycardia. It should be given as a 50 to 100 milligram bolus, followed by a continuous infusion of 1 to 3 milligrams per minute. Calcium chloride may be effective for increasing myocardial contractility where there is a weak beat after a rhythmic ECG has been restored. Morphine sulfate is not indicated for resuscitation purposes. However, it should be available for relief of pain in myocardial infarction and in pulmonary edema. Oxygen should be considered an emergency drug and should be administered as soon as available. During the CPR emergency, drugs should be administered intravenously. A cut-down or long-term intravenous route should be established as early as possible. This should be accomplished without any interruption in CPR. Intracardiac injections require interruptions in external cardiac compression and should only be used where an intravenous line is not available. This route should be limited to epinephrine early in the cardiac arrest. Advanced life support also requires disposition of the patient. This includes stabilization of the patient at the site, communications, use of mobile life support units, transportation, admission to special care units, and post-resuscitation care. We have now reviewed the principles of basic and advanced life support. To assure proper performance of CPR, all trainees must have practice and testing in small groups on lifelike mannequins under certified instructors. No CPR course is complete without training to perfection under supervision. The reenactments which follow illustrate how CPR should be applied in real-life situations. Resuscitation emergencies can occur anywhere in a hospital. This requires well-organized CPR teams and a coordinated plan of action.
An unmonitored arrest.
The alarm is sounded. The resuscitation team is called into action.
Dr. Hart, 725. Dr. Hart, 725.
The first rescuer has already checked breathing and pulse and has started CPR. As soon as possible, a bedboard is used to provide a firm support beneath the patient. A bag valve valve mask unit with the reservoirs connected to the oxygen line. CPR is continued with the two-rescuer technique. The emergency cart and additional members of the team are on their way. Now, what happened? A sudden collapse? A leg injury? Could be a pulmonary embolism. Hook up the scope. Get the IV ready. Prepare the drugs. The anesthesiologist is on her way from surgery. Emergency drugs have been given. The oscilloscope shows weak complexes, but there is still no pulse. Intubate the trachea as soon as possible. Resume resuscitation immediately. Check the pulse. There is a pulse now, but it's weak. Check the oscilloscope. The rate is rapid, and there are S waves. Probably a pulmonary embolism. There is now a palpable pulse and a rhythmic ECG. The pupils react to light. The patient has an effective blood pressure. She can now be moved to a special care unit for continued monitoring and further treatment. Even when a patient is being monitored, constant attention is required. Absent pulse and a flat electrocardiogram. These indicate cardiac arrest. A precordial thump and effective ventilation with oxygen may restore a pulse to a patient with a witnessed arrest. A palpable pulse and a rhythmic ECG have been reestablished. Drugs may be required to stimulate the heart and to combat acidosis. The return of a regular electrocardiogram, normal color, palpable peripheral pulses, and reactive pupils indicates that the emergency has been successfully treated. However, the patient will require additional monitoring and intensive follow-up care. Heaviness and pressure in the center of the chest. Radiation to the shoulders, arms, or neck. These may be early warning signs of an impending heart attack.
A sudden collapse. Check for unconsciousness. Tilt the head and check for breathing. No breathing. 4 quick breaths. Check the pulse. No pulse.
Call for help. Locate the xiphoid. Start one rescuer CPR. The rescue squad is called. As soon as 2 rescuers are available, interpose a breath between each 5 compressions. The Central Dispatch Center has received the call and sends a rescue squad and an ambulance to the scene. At the scene, CPR is continued without interruption while waiting for help to arrive. Basic life support is continued while preparations are made for advanced life support. The heart is in ventricular fibrillation. Stand clear. The oscilloscope shows a rhythmic electrocardiogram. A palpable pulse indicates that an effective heartbeat has been restored. The rescue squad contacts the hospital by means of its radio telemetry.
General Hospital, this is Squad 9. How do you read?
Squad 9, this is General Hospital. We read you loud and clear.
General Hospital, Squad 9. We have a 44-year-old white male who collapsed at home after having severe chest pain. His wife and son started CPR. We arrived in 3 minutes and he was in ventricular fibrillation. Have defibrillated with 400 watt seconds. Patient is still unconscious and does not have spontaneous breathing. Request permission to use esophageal airway. Over.
10-4 in the esophageal airway, Squad 9.
10-4, General Hospital. Esophageal airway passed. Transmitting lead to ECG. Ready to start IV. Over.
10-4, Squad 9. ECG shows normal sinus rhythm. Transport as soon as you have IV established. Admit directly to coronary care unit. Over.
10-4, Hospital. Understand. Hey, he's in VF again. Stand clear. He's converted on the scope. Does he have a pulse?
Good pulse.
The hospital directs the rescue squad to administer a bolus of lidocaine because of recurrent ventricular fibrillation. The infusion rate of the lidocaine drip is also increased. An ambulance has also been dispatched to the scene to assist the rescue squad and to transport the patient to the hospital. The use of advanced life support has now stabilized the patient at the scene. Continuous monitoring and treatment will be maintained while he is transported to the hospital. The rescue squad remains in radio telemetry contact with the hospital throughout the transfer. Vital signs and electrocardiogram are continuously, and treatment is modified as required.
General Hospital, Squad 9, we are now en route. Scope shows normal sinus rhythm with occasional PVCs.
10-4 Squad 9, give a 50 milligram bolus of lidocaine and increase the lidocaine infusion rate to 3 milligrams per minute. What are his vital signs? Over.
General Hospital, Squad 9, 50 milligram lidocaine bolus given. Lidocaine infusion rate increased. Patient semi-conscious. Blood pressure 125/78. Pulse 95. Spontaneous respirations at 16 per minute. Over.
10-4 Squad 9, we're ready for him in the CCU.
Optimum management of cardiac arrest at the scene and en route to the hospital requires this type of highly trained personnel and special equipment. However, in communities where these are not available, provisions must be made to continue basic life support until advanced life support is available. The following scene shows how this can be done. A busy young executive's hurried trip to the airport may be the forerunner of a shattering heart attack. A rescue squad is needed. Further help is summoned. If the victim is unconscious and not breathing, open his airway and give 4 quick breaths. Check the pulse. If the pulse is absent, begin CPR. Basic life support is continued without interruption while preparations are made to move the victim. Since these rescue personnel have not been trained and are not equipped to perform advanced life support, a portable mechanical unit for ventilation and chest compression is used to provide continuous CPR during transportation. Every effort must be made to avoid interruptions in resuscitation. One rescuer must always remain with the victim to keep the head extended, to check the pulse and pupils, adjust the controls, and assure proper position of the compressor. Suctioning the air passages is a vital step in life support. At the hospital, qualified medical and nursing personnel will take over in the fight against sudden death. Advanced life support measures are started immediately without interrupting basic life support. The trachea is intubated quickly. The oscilloscope shows ventricular fibrillation. Sodium bicarbonate and epinephrine are administered intravenously. Saline pads are applied and the defibrillator charge is delivered. Sometimes multiple shocks and additional drugs are required. A palpable pulse and a rhythmic electrocardiogram indicate a successful resuscitation. Once again, careful adherence to the principles of cardiopulmonary resuscitation have helped to fulfill the prescription for life.